I'm Christina Taylor, one of the PGY4s. This is part of the Airway lecture series. So big thanks to the Airway lecture team. And we'll go ahead and get started. So we're going to go over some like clinical cases, kind of going over a little bit of RSI versus doing awake intubations, kind of the difference between the two, what things can make intubation more challenging, some of the steps of the awake intubation, and we'll show some videos as well. So with these two clinical cases, with the first one, we have a 46-year-old female, has a history of asthma, previously been intubated, morbid obesity, coming in with difficulty breathing, has increased work of breathing, and on lung exam, minimal air movement. This patient's placed on BiPAP, given duonebs, mag, solumedrol, has improved air movement, is protecting their airway, but still has increased work of breathing and appears to be tiring out at this point. In contrast, we have a 28-year-old male with a history of seizures on Keppra, presents actively seizing while in triage. The family says he's had 2 seizures today, the last one only about 2 minutes prior to the start of this one, and has not returned to baseline. So when we're considering many of these patients and we're thinking we're moving toward intubation, big things we're trying to see is this a patient that would need rapid sequence intubation, or would you consider more of an awake intubation? So let's go over rapid sequence intubation. What does this really mean? This is when you're using induction and neuromuscular blocking agents to facilitate sedation and paralysis. The big thing being that you actually want to paralyze these patients. It's really ideal for your patients that are more acutely crashing. They need an airway on the quicker side. You might not only have like 5-10 minutes for you to actually secure an airway. RSI is what we're used to. It has the highest probability of success for intubating patients in the emergency setting. There are a lot of studies showing this that actually support that. When you're doing an RSI, routinely, when we look at like anesthesia, when they come down or when they're doing a lot of these intubations in the operating room, they're bagging the patients, but they also know this patient, they know when they were last had a meal, they're kind of at least aware whether this is an empty stomach, whether it's not. A lot of times when we're doing this, we're doing it more in the emergency setting. Yeah, you want to maximize oxygenation, but you're not trying to excessively bag these patients. Now, in contrast with an awake intubation, you're using topical anesthesia and sedative medications. You're trying to maintain their airway reflexes and spontaneous breathing. You don't want to paralyze them so that they're not having any of their spontaneous breathing. These are the patients that you would consider an awake intubation when you think they might have more of a difficult airway, or they might have challenging physiologic characteristics. Like some of your like DKA patients with a severe acidemia, might be hypoxic, hypotensive, might be RV failure. These are the patients that you're worried that you might not be able to oxygenate or ventilate effectively. And this is for patients where you have more time. If you don't have time, you shouldn't be necessarily thinking of these awake intubations because it's going to take a second for you to get everything together, position them correctly, and be prepared for this. So when we're thinking about these challenging intubations, what's making a challenging airway? So you have things that are like your anatomical causes and your physiologic causes. So things like angioedema, Ludwig's angina, your body habitus, obesity, OSA, neuromuscular diseases. That can cause like kind of your hypoventilation if they've had a history of a difficult intubation. If you anticipate that if you were to end up needing to crike this patient, they'd be very difficult to crike based on their anatomy. They might have a really short neck or just a lot of tissue there, not great landmarks. These are, as we said, kind of like patients that are maybe severely acidotic, where you're worried about their physiologic characteristics. They might be difficult to ventilate. They might have trismus, really limited mouth opening, where you might actually need more of an actual like paralytic to help assist you. where they might have C-spine trauma. They might have prior like C-spine disease, like your rheumatoid arthritis patients. You might have had significant cardiopulmonary risk factors that make this like a very high risk intubation. And then the other thing that we don't always think of, just based on where our hospitals are, is this patient going to potentially need to be transferred far away? You might be working at more of like a single coverage setting, and maybe this patient's okay now, but will they survive for that full transfer without needing to be intubated en route? So all of these kind of patients are ones you might consider for something like an awake intubation. However, this is not going to be something you're going to want to do in a patient who's actively vomiting, has a large volume hemoptysis, where you're going to have a lot of like trouble being able to visualize this. You don't have that same kind of security where you do when you've already like given a full paralytic along with this. So when we go back to these clinical cases, in the first case, you have a patient who's been previously intubated, who has morbid obesity, already is improving on BiPAP, but getting tired. And so this patient needs to be intubated, but we might have a little bit of time. We're definitely going into that direction. Second patient, they're more in status picture, not protecting their airway, high risk of hypoxia, and we really need to help paralyze this patient to actually like relax the jaw, because we're not really going to easily be able to intubate them when all their muscles are fully clenched like this. So if you're deciding to do an awake intubation, it can be nerve-wracking for you. This might not be something you're used to doing, but the other thing is it's probably pretty nerve-wracking for the patient. So the big thing you want to do with all of these patients is you want to actually coach them through it. And that's going to be a really important part of preparing them for what's about to happen, and also knowing that if this doesn't work, what's your backup plan? What are you going to do after this? You have all the tools ready for that, because you might prepare for this, something might go wrong, and just like you would with RSI, you want to know what you're going to after that. So with these awake intubations, regardless of whether you're doing an orotracheal intubation or a nasotracheal intubation, general steps are essentially the same. You're going to dry, topicalize, sedate, and then intubate. So what does this actually look like? So when we're talking about an orotracheal intubation, you have a couple different options for drying secretions. And so you can use like 0.2 milligrams of glycopyrrolate, which we have we have it pretty easily available at like the main pharmacy at County. This is a preferred agent because administering it, it's not going to cross the blood-brain barrier. You can also use atropine. The dosing is more close to like 0.01 mg per kg. It will also help to grease secretions, just like we do use it in various like toxidromes. But once you're actually applying it, you're going to be waiting about like 15 minutes, and then you actually want to like suction. You want to help to create a whole dryness in their mouth. So a lot of times that involves you even like using gauze to then pat down the mouth. Now, not everybody like does this. And if you're not having access to this, you can still do just your gauze without using the actual like agents. And the other thing that some studies have shown is you can also use things like Zofran that can also just further help blunt the gag reflex. But this is going to be like really uncomfortable. And so you gotta prepare the patient that it's going to feel really dry. It's not going to feel really great to have all of this preparation. Now, if we're doing nasotracheal intubation, it's less of all the drying of secretions in the mouth, but now you want to actually pay attention to the nares themselves. So for this, you can use 0.25 to like 1% phenylephrine, or you can use like 0.05% oxymetazoline spray. All of this is meant to help constrict the mucosa in the nose and reduce any epistaxis, because you're already going to be kind of inserting something that has a potential for trauma. You don't need like on top of it a whole bunch of epistaxis then created once you're starting and making it really hard to kind of visualize what you're doing. Now, when we're talking about topicalizing, for this, you're going to be using your lidocaine. And this is going to be where I'm going to kind of like the only times we're actually using our nebulized lidocaine. You can nebulize like at like 4% lidocaine. You can put like 4 to 5 cc's and run it over about like 5 liters per minute. You do this for a couple minutes, and that's going to really help to kind of create that nebulization actually more intraoral. And so you kind of run it just like you would like an albuterol neb. The difference is now you're just using the 4% lidocaine. This is going to provide the anesthesia effect that we're looking for. And you can use these atomizers to give the lidocaine. I don't know if we have any accessible to us, but the biggest kind of point of it is that you have a flexible tube at the end where you can insert it. It goes a lot further back, and then you can actually use it to give the lidocaine. The tip is more flexible, which helps so that you're kind of not damaging any structures. And you can alternatively, if you don't have an atomizer, other things people use are things like 4% viscous lidocaine. You can have them like gargle it. You put it on a tongue depressor, stick it more posterior. Still, with all this, it's not going to be super comfortable, but it does help if you're actually trying to prepare them so that they don't end up really not tolerating this procedure well. Now, if you don't have an atomizer, which you may or may not, depending on where you're working, you can also kind of create your own. So you could take like one of our long 20 gauge long IV catheters, you can attach it to a 3-way stopcock and attach the other end of the stopcock to oxygen tubing and end up then setting that at about 5 liters, and then on the other side attach a syringe, so that as you push the syringe and you actually have the oxygen tubing to help nebulize it, and then your long IV catheter is effectively working to be something that you can, as a flexible tip, to put back in the oropharynx. So that's one option if you kind of don't have a ton of options, but you still want to at least try to see whether an atomizer would help. Now, when we're talking about these nasotracheal intubations, you're topicalizing with your viscous lidocaine. So always with this, it's going to be your 4%. You can end up putting like a lubricated nasal airway. It's about the same size of the ET tube that you're trying to use. That can help to actually dilate that passageway, as well as it also just then is providing some of that anesthesia to the nair itself. So you can insert that. You want to use this always with anything that you're doing with the nairs. You want to use the more patent nair. So you might kind of have to look at both and see which one has like an easier movement of these MPAs inside of it. Now, we're keep talking about lidocaine, but one thing we got to talk about is also the toxicity. We're very used to using like sub-Q lido, sometimes IV lido, but we don't really use a lot of nebulized lidocaine. And the thing we worry about with any kind of lidocaine toxicity is when you're getting to more like your serum concentrations closer to 5, you're starting to see a lot of these effects, and that's more where you're getting the actual toxicity. So there's some studies that have actually looked into the lidocaine plasma levels and how they correspond after administering specifically nebulized lidocaine. And they found that if you're giving about like 5 cc's of that 4% topical lido solution and you're putting it in that atomizer, and so that's basically 1 round of you putting in anesthesia through the mask, that's giving a dose of about 200 milligrams of lidocaine. Now, if you did that twice, you're at 400 milligrams. When they actually looked at what administering 400 milligrams nebulized lido corresponded to in your plasma concentrations, it actually only peaked at about like 1.1 of the like micrograms per milliliter, which is a lot lower than the 5 that's really the point we see of the toxicity. So if you're considering this, it's generally thought to be safe that you could administer this 2 to 3 times and still be below your toxic level. So you can at least know that, okay, I can use this a couple times to be able to really create that anesthesia effect. Now, when we're talking about sedation, we have a couple options, and everybody kind of has their different preference on these. You can end up using 20 milligram aliquots of ketamine, and you can just use the ketamine alone. You don't always have to use and do a ketofol. You could also just do ketamine alone, which some people like to do. One of the big risks of ketamine, obviously, is that you do have a risk of laryngospasm. And once you're putting this patient into more of a laryngospasm, you might not be able to get them out with anything other than a paralytic. So at that point, you kind of have converted to an RSI, but not really intentionally. You might not really be prepared, and now you got to move a lot faster. So if you're using ketamine, some of the studies are, for the most part, showing that you're going to be moving in these like 20 milligram aliquots. You wait like 2 minutes, see how it takes effect, see how they're doing, and then see if you need to give more. If you're doing more of a ketofol, you're going to do like 50 milligrams ketamine, you do 50 milligrams propofol, and you end up putting them in a 10 cc syringe. And so you can give 1 to 2 cc's of now the combined ketofol about every minute. So you're going to have a total of that 10 cc's, and you're going to kind of be going real slow, and you want to see how this has effect and make sure that it's actually not over sedating them, that they're still, remember, you're not trying to fully sedate and paralyze. So kind of going very carefully. Other thing you can use, you can do a low dose Versed. With that, you could do like 0.5 to 2 milligrams IV, but you really don't want to go higher than like 5 milligrams total. Some people have proposed using things like Precedex, but one of the concerns with it is it might not really work fast enough. We don't use Precedex nearly as often in like an ED setting, so it's also a drug that not everybody's super familiar with. Now, when we're doing the orotracheal intubations, like with anything else, you're still doing your normal steps. You're pre-oxygenating. With these patients, it's helpful to have the nasal cannula on. The other thing is, with all of this, it starts to be scary. No one wants to kind of have any kind of awake sense that they're about to have a tube down their throat. So with some of these patients, beyond coaching, you might end up needing to consider, do you need like soft restraints? Are you worried about them trying to then go and pull this out as you're trying to actually do this? The other thing is, with this, if at any point, let's say you start, and let's say you wanted to start by doing a bougie and go through the cords, once you've passed the tube through the cords, like many of these patients, they're going to start like coughing at that time. You can also still push something like ketamine or ketofol. But if you're at that point, like pushing more of these medications, then you're once again kind of risking like converting just to like RSI. But if you've already gotten through the cords, it may not matter as much when you're that far in. The other thing with these patients that you got to remember is, because like we talked about, these are patients that might have more difficult anatomy. You might not be doing it with them like supine. You might end up having them with the head of the bed fully up. Got to also prepare how you're going to do this. Standing up intubations, they can be technically difficult, and you're really trying. A lot of times these patients, if they're more obese, might really need a lot of like the towels or sheets or anything to really move that, so that you have your sternocleidomastoid notch in line with the ear. So you really want to like maximize that, but be careful, because you might be doing this, and if you're standing and you want to make sure that you really have everything optimized, and ideally really have someone or a couple people there helping you. So that's one of the big things that you want to consider with these. Now, we have access to our fiber optics, and those can really be helpful if this is something you're considering. So with this is a B-flex. And so the big thing that you'll note with this is at the top here, you're basically going to be plugging it in to your glide scope. So just like you would plug in one of your like Mac blades, you plug it into the top here. Now you're going to have your long actual like fiber optic tube itself. And many of these end up having essentially like a notch for you to put the ET tube. So kind of like you would prepare the actual ET tube when you're doing it with a bougie, you can load it on at the top and kind of have it secure so it's a little out of your way as you're doing this. When you are doing it, you really want this totally upright. And when you look at the actual kind of attachments to it, you have your suction tubing that can go right there. You'll have your lever, and then down here where you can barely see it is also where you can put your syringe to insert the lidocaine. So you basically have at the very bottom effectively like an atomizer if you're using the fiber optic tubing. So what does this all actually look like? So this, do not try this at home. This is a very bad idea. Is there sound? Now, the even more terrifying part of this is that as he's doing this, he ended up allowing someone else to insert through more of a jet insufflation to lidocaine the actual cords, and then still did it on himself. He did, but he ended up doing it through the actual crike. He didn't crike himself. Yeah, he was surprisingly very, very comfortable with that entire procedure. Now, the other one that you're doing, if you end up doing more of a nasotracheal intubation, you got to remember your anatomy, it's kind of, you're going a long course. You're going to be running into kind of a lot of different grooves, bends. It's not really going to be pleasant at all for the patient. Even like we know NG tubes aren't super pleasant for the patients. This is even worse. But if you are doing it, it's going to look something like this. See it. So in this case, with this, he's basically pulling his tongue forward so that you can help with your anatomy, so that you can actually insert it through. Incredibly unpleasant. Take a deep breath in. Should be injected through the working channels across the however, we at least think we're bad at after breaking the board, we're driving and there you go. So as I said, definitely don't do this on yourself. And if you're very brave, I suppose you could do it on someone else, but please make sure they have volunteered. Your take-home points, so consider awake intubations in some of these patients that have very difficult airways. They'll need to really be coached throughout this. It's, as you saw, not a particularly pleasant experience, although in the first one, he seemed like he was having a lot of fun. Get to know your equipment, know what meds you have access to, what your hospital has access to, what meds you're actually comfortable using for this, and plan out your approach. Always have a backup. And remember to breathe and help the patient to breathe.